This video is about general pharmacology from Mrcp. So this is about revision of the whole topic. It may not be in very much details. So the first thing that comes is pharmacokinetics. Drug metabolism usually involves two types of biochemical reactions: phase 1 and phase 2 reactions. So what are the two reactions? Phase 1 includes oxidation, reduction, and hydrolysis, mainly performed by the P450 enzyme, but some drugs are metabolized by specific enzymes, for example, alcohol dehydrogenase and xanthine oxidase. Products of phase 1 reactions are usually more active and potentially toxic. So we'll come to this. Next is phase 2 reaction, conjugation. Products are typically inactive and excreted in urine or bile. Glucuronyl, acetyl methyl sulfate, and other groups are typically involved. The majority of phase 1 phase 2 reactions take place in the liver. So both pharmacokinetics phase 1 and 2 take place in the liver. So you need to remember this: drug metabolism, phase 1 oxidation, reduction, hydrolysis, and phase 2 conjugation, ORH. Okay, what's first pass metabolism? It's a phenomenon where the concentration of a drug is greatly reduced before it reaches the systemic circulation due to hepatic metabolism. So the drug concentration gets reduced due to the hepatic metabolism. Drug, liver, system. As a consequence, much larger doses are only needed orally than if given by other routes. So higher doses are supposed to be given orally so that it doesn't get decreased like by a large margin. This effect is seen in many drugs including aspirin, isosorbide dinitrate, crystal trinitrate, lignocaine, propranolol, verapamil. Zero-order kinetics describes metabolism which is independent of the concentration of the reactant. So the concentration is not really dependent on the metabolism. This is due to metabolic pathways becoming saturated, resulting in a constant amount of drug being eliminated per unit time. So the pathways are saturated, which means there's constant elimination. Okay, constant amount of drug being eliminated at per unit time. This explains why people fail a breathalyzer test in the morning if they have been drinking the night before. Drugs exhibiting zero-order kinetics are ethanol, as alcohol, heparin, salicyclate, phenytoin. So this is like constant elimination. That's what you need to remember. Okay. Next comes drug affected by acetylator status. Isoniazid, procainamide, hydrolazine, dapsone, sulfasalazine. Well, in this pharmacology section of Mrcp, there's a lot of things to remember rather than understanding. There's a lot of understanding, but then remembering is more important here. So acetylator status: 50% of UK population is deficient in hepatic and acetyltransferase. Okay. P450, a very important one. P450 dependent drug. You have to remember WOPTD: warfarin, estrogen, phenytoin, theophylline, digoxin. So there are these P450 inhibitors and P450 inducers. So what you need to remember is what really happens here. P450 inhibitors decreases the metabolism of these medicines. So increases the toxicity, as in these medicines don't get metabolized, so it keeps on growing up. So okay. So what happens? Okay, what are the inhibitors here which can cause toxicity of these medicines? It can be acute alcohol intake, allopurinol, amiodarone, cimetidine, omeprazole, dapsone, imidazole, fluconazole, ketoconazole, isoniazid, macrolides, quinolones. All these are inhibitors, so this can cause toxicity when given with these. Very important. Quinolones, quinopristine, sodium valproate, spironolactone, fluoxetine, grapefruit juice, protease inhibitor like ritonavir, indinavir. On the other hand, P450 inducers can increase the metabolism of this, so they decrease the effect. So in case you're giving theophylline and you're giving one of these inducers, the effect of theophylline will reduce because this will actually increase the metabolism of this drug, of theophylline. So decrease effect of theophylline. So what are the P450 inducers? They can be anti-epileptic like phenytoin. Okay, so Anti-epileptics like phenytoin, carbamazepine. We have to note that valproate is in the inhibitors, so it can cause toxicity. There is barbiturate, chronic alcohol intake, griseofulvin, quinidine, rifampicin, smoking. It's actually an inducer, decreases the effect of these things. St. John's wort, sulfur drug, tetracycline, nevirapine. So this is a very important topic that you actually need to remember for the exam actively. Like there will be questions asking you about P450 inhibitors or inducers. Well, there's like not many mnemonics regarding this. You just have to remember this chart for inhibitor. All these. Some things which are very common, like quinolones, we use fluconazole, amiodarone. All these are very important inhibitors. Okay, carbamazepine is an inducer of the P450 enzyme. We know that system. This in turn increases the metabolism of carbamazepine itself because yeah, so it's weird. One exception. Okay, drugs that can be cleared by hemodialysis. Dialysable drugs are barbiturate, lithium, alcohol, salicylic theophylline, all these. Okay, including methanol and ethylene glycol. That's where you give dialysis. Theophyline's charcoal hemoperfusion is preferable. Non-dialysable can be TCA, benzodiazepine, then alprazolam, midazolam. These are not dialysable. Dextropropoxyphene, all these, digoxin, beta blocker, you can't dialyze them. Okay, this is also something you can remember with this mnemonic called BLAST, that is barbiturate, lithium, alcohol, salicylic theophylline. Drugs to avoid in renal failure. So in renal failure, which drugs you need to avoid? Lithium, NSAIDs, antibiotics, tetracycline, nitrofurantoin. So which are safe? Erythromycin, rifampicin, diazepam, warfarin are safe in acute renal failure, but you need to do dose adjustment for. We see that every time, like for meropenem, you can decrease the dose into renal dose. Like cephalosporin is also there. Broad spectrum antibiotic, penicillin, cephalosporin, vancomycin, gentamicin, streptomycin, decoxin, atenolol, methotrexate, sulfonylurea, furosemide, opioid. These all need dose adjustments for renal failure. Okay, drugs, drug-induced impaired glucose tolerance can be thiazide, furosemide. These are less common. Steroid, tacrolimus, cyclosporin, interferon alpha, nicotinic acid. All these beta blockers cause a slight impairment of glucose intolerance. They should also be used with caution in diabetics, so they can interfere with the metabolic and autonomic response to hypoglycemia. So we all know that from before, but these things are quite important. Okay, drug-induced liver disease, also a very important topic. Which drugs can do that actually? It's generally divided into hepatocellular, cholestatic, or mixed. So depending on the way it's affecting. This is, however, considerable. There is, however, considerable overlap with some drugs causing a range of changes to the liver. Hepatocellular, like alcohol, amiodarone, anti-TB, halothane, MAOIs, methyl-dopa, paracetamol, sodium valproate, phenytoin, statins. These can actually this can actually give a hepatocellular picture. And cholestasis and hepatitis, anabolic steroids, testosterone, like antibiotics like flucloxacillin, coamoxiclav, fibrates, important. Statins here important, fibrates here important. Oral contraceptive pill, phenothiazine, chlorpromazine, prochlorpromazine, rarely nifedipine, sulfonylurea. Okay. Liver cirrhosis can be caused by amiodarone, methotrexate, methyl-dopa. These, as I've told you before, that for Mrcp pharmacology exam, a lot of things need to be recalled rather than understand here. Yeah, you can go for the metabolism, how it's actually causing all these. You can understand to have a better understanding and recalling of all the data. But more or less, it's more about the lists, like which drug causes what. Okay, the drugs that cause visual disturbance is also very important. Cataract can be caused by steroids. Corneal opacity, amiodarone, indomethacin, optic neuritis, ethambutol, as we know from childhood of medicine. Amiodarone, metronidazole can cause optic neuritis as well. Retinopathy, chloroquine, quinine, blue tinge and vision, sildenafil, yellow-green tinge, digoxin. Sildenafil can cause both blue discoloration and non-arthritic anterior ischemic neuropathy. Okay. Drugs causing gingival hyperplasia, overgrowth of gum, phenytoin, cyclosporin, and calcium channel blocker, especially nifedipine, something you need to remember, can do that. And other causes of gingival hyperplasia include AML. Okay, drugs causing urticaria can be aspirin, penicillin, NSAIDs, opiates. These are like more uh, likely to cause urticaria, so that's why these names are given here. Drugs in AIP, safe for acute intermittent porphyria. Paracetamol can be given, aspirin, codeine, morphine, chlorpromazine, beta blocker, penicillin, metformin. These can be given. Not safe will be alcohol, barbiturate, benzodiazepine, Haltane, oral contraceptive pill, and sulfonamide. Okay, drug-induced hematological abnormalities. A lot of lists will be available here, and you have to go through everything, remember everything. It's very interesting actually. Hematological abnormalities are what we find in everyday hospital rounds. Thrombocytopenia is so something very common to see. Well, heparin, then apiximab, NSAIDs, diuretics like furosemide even can cause thrombocytopenia. Quinine, antibiotics like penicillin, sulfonamide, rifampicin, and also linezolid. Anticonvulsants like carbamazepine, valproate. All these can cause thrombocytopenia. Okay, pancytopenia, like all the hemoglobin total count and platelets going down. Cytotoxics can cause this. Antibiotics like trimethoprim, chloramphenicol, anti-rheumatoid gold, penicillamine, carbimazole, anti-epileptic like carbamazepine can cause pancytopenia. Sulfonylurea like topitamide can also cause it. Okay, drug-induced photosensitivity. So this is also a very common question. All these are very common questions in Mrcp Part 1, which we're studying for. Drug-induced photosensitivity can be thiazide, tetracycline, and for these, the question will be like this: that a person is working in the garden and he's having rash in forearms, face, and which drug may be responsible for this? So thiazide is there, tetracycline, sulfonamide, ciprofloxacin, amiodarone, NSAIDs, psoralen, sulfonylureas. All these can cause all these, photosensitivity. Rash on the forearms and face is a typical of photosensitivity rash. Okay, then chemotherapy side effects. Nausea and vomiting are common side effects of chemotherapy. Risk factors for the development of symptoms include anxiety, age less than 50-year-old, concurrent use of opioid, the type of chemotherapy used. All these are important. For patients at low risk of symptoms, the drugs such as metoclopramide may be used first line. For high risk patients, then 5-HT3 receptor antagonists such as ondansetron, like Amistat, are often effective, especially if combined with dexamethasone. Very important. Okay, another thing which is very commonly done in the hospital setup: therapeutic drug monitoring. So, therapeutic drug monitoring. First thing is phenytoin. Trough levels. When do you send the drug monitoring level? Trough levels immediately before the dose. Like before the dose, you send for phenytoin. Cyclosporin, trough levels immediately before dose. So this is also same before dose. Digoxin at least 6 hours post dose, and lithium range. So digoxin is after giving the drug, you send the therapeutic monitoring level after 6 hours. Okay, and then for lithium the range is 0.4 to 1. It's a very small range. So take 12 hours post dose. So after giving the drug post dose, it's like lithium. So PC will be like before, and DL will be after 6 and 12. So that's all you need to remember. Corticosteroids, the equivalence: hydrocortisone equivalence, 1 milligram prednisolone is equals to 4 milligram hydrocortisone, and 1 milligram dexamethasone is 7 milligram hydrocortisone. So the most powerful is dexa, as in. So what you have to remember is this chart, that is DPH. Dexa 1 milligram is 7 milligram prednisolone, and for prednisolone 1 milligram prednisolone is 4 milligram hydrocortisone. So dexa to hydrocortisone is 28 milligram. So one dexa is 28 milligram hydrocortisone. So patients on long-term steroids need their dose to be doubled when they are actually in ill condition. So they have to measure up and double the dose maybe. Gradual withdrawal of prednisone is needed when. So when do you give a withdrawal course? As in when tapering. Patient is on prednisone for more than 3 weeks. That's when you start tapering. Patient is on more than 40 milligram for 1 week. And patients will receive repeated courses. Patients on long-term steroids need osteoporosis prophylaxis. Refer to the musculoskeletal section because they may develop osteoporosis. Okay. Botox, something which many people are very aware of. What is it? So in this one, as well as publicized cosmetic use of Botox, there are a number of license indications like blepharospasm, hemifacial spasm, focal spasticity, including cerebral palpitations, hand and wrist disability associated with stroke, spasmodic torticollis, severe hyperhidrosis of the axilla, achalasia. So all these. Achalasia is something you need to remember because it's more common. Okay, the next would be isotretinoin. Difficult to manage. Okay. Isotretinoin is an oral retinoid used in the treatment of severe acne. We know that two-thirds of patients have a long-term remission or cure following a course of oral isotretinoin. Adverse effects can be teratogenicity, must be using two forms of contraception, pill and condom. Then dry skin, eyes, and lips. The most common side effect of isotretinoin: low mood, depression, raised TG, air thinning, nosebleeds caused by dryness of the nasal mucosa, benign intracranial hypertension. So all these can be caused by isotretinoin. Isotretinoin treatment should not be given combined with tetracycline for this reason. So this can cause PIH. Okay, smoking cessation therapy is also important. There's good evidence that individual smoking cessation counseling is more effective at helping people to stop smoking compared to receiving minimal support. The best way to stop smoking is to use a combination of behavioral medication, support, and medication. The first step is to set a quit date and commit to it. Offer only one of the following, do not combine. So you can give one of these three. They either give nicotine replacement therapy, or you can give varenicline, like nicotine receptor partial agonist, or bupropion, norepinephrine and dopamine reuptake inhibitor, and nicotinic antagonist. So the choice should be made. On individual basis, considering patient's previous experience with quitting, preference, and contraindication. NRT, varenicline, or bupropion should normally be prescribed as a part of a commitment to stop smoking on or before a particular date. Prescription of NRT, varenicline, or bupropion should be sufficient to last only until 2 weeks after the target stop date, and then patient should be assessed for further prescription. So only for 2 weeks can be given. Okay, so let's see what are the protocols here. Okay, so first NRT, nicotine replacement therapy. Adverse effect can be nausea and vomiting, headaches and flu-like symptoms. NICE recommended offering a combination of nicotine patches and another form of NRT, such as gum, inhalator, lozenge, or nasal spray to people who show a high level of dependence on nicotine or who have found single forms of NRT inadequate in the past. Varenicline should be started 7 to 14 days before the target stop date. Should be started. The recommended course is of 12 weeks, but patients should be monitored to regularly and treatment only currently if no smoking. If successful in 12 weeks, prescribe further 12 weeks to help maintain cessation. So this is like 12, and then start 7 to 14 days before the target stop date. Nausea is the most common adverse effect. Others include dry mouth, headache, insomnia, abnormal dreams. So nausea would be the most common effect. That's for varenicline. Should be used with caution in patients with history of depression or self-harm, contraindicated in pregnancy and breastfeeding. For bupropion, it should be started 7 to 14 days before target date as well. Just like varenicline, if no effect after 7 weeks, discontinue. So if there's no effect after 7 weeks, you can stop this drug. Bupropion is contraindicated in epilepsy, CNS tumor, history of eating disorder, history of bipolar disorder, severe hepatic cirrhosis, pregnancy, and breastfeeding. Prescribe with caution in people, elderly people, alcohol abuse, history of head trauma, diabetes, drugs that lower seizure threshold. Okay, if the person prefers to use e-cigarettes to help them quit, e-cigarettes cannot currently be prescribed or supplied by smoking cessation clinics. Some people find e-cigarettes to help them stop smoking. They still can receive support and advice from a smoking cessation clinic, and recommend that they do this to give themselves the best chance of quitting. Consider suggesting e-cigarettes as a way of stopping smoking to people who have tried unsuccessfully to stop smoking using other methods. So if they've tried everything and they can't quit, they can try e-cigarettes as well. Okay. Next topic is pregnancy and medications. What are contraindicated and what are not? So very few drugs are known to be completely safe in pregnancy. The list below largely comprises of those known to be harmful. Some countries have developed a rating system. So contraindicated in pregnancy would be these drugs: ACE inhibitor ARBs, statins, warfarin, sulfonylurea, retinoids, including topical, very important, cytotoxic agents. And for antibiotics, there can be tetracycline, aminoglycoside, sulfonamide, trimethoprim, quinolone. So quinolone includes ciprofloxacin, ciprofloxacin, and moxifloxacin. Majority of antiepileptics, including valproate, carbamazepine, and phenytoin, are known to be potentially harmful. Decision to stop such treatment, however, is difficult, as uncontrolled epilepsy is also a risk. So you have to weigh the two decisions, like whether to give the antiepileptics or not to give. Okay, breastfeeding contraindications. Uh, Galactosemia, viral infections. UK, WHO, and US guidelines recommend HIV mothers should not breastfeed their babies. Should not. So it's transmissible. What are the safe medicines in breastfeeding? Antibiotics like penicillin, cephalosporin, trimethoprim. Endocrine medicines like glucocorticoids avoid a high dose. Levothyroxine, they're safe. Epilepsy drugs like sodium valproate, carbamazepine, salbutamol, theophylline, asthma drugs, psychiatric drugs like TCA, antipsychotics. Then hypertension, beta blocker, hydrolazine methyl topa, anticoagulant like warfarin and digoxin. Not safe would be antibiotics like ciprofloxacin. It's not safe in pregnancy as well. Tetracycline, chloramphenicol, sulfonamide. Psychiatric drugs like lithium, benzodiazepine, clozapine, aspirin, carbimazole. These are not safe for breastfeeding mothers. Sulfonylurea, cytotoxic drug, amidoron. Okay. So British HIV Association guidelines advise that the mothers who choose to breastfeed should be supported to do so. The BNA advises the amount is too small to affect neonatal hypothyroidism screening. Okay, these are like the stars given there. Antipsychotics, clozapine should be avoided. Okay. Breastfeeding is acceptable with nearly all anti-epileptic drugs, taken in normal doses with the possible exception of barbiturate. Okay, now let's look at the palliative care prescribing. The Scottish are the leaders of palliative medicine in the UK. You may always refer to Scottish palliative care guidelines online, they are freely available. Selected points: the breakthrough dose of morphine is 1/6 the daily dose of morphine. That's the breakthrough dose. For patients who are receiving opioids, consider prescribing laxatives and antiemetics as well. Okay, opioids should be used with caution in patients with CKD. Alfentanyl, buprenorphine, and fentanyl are preferred. Metastatic bone pain may respond to NSAIDs, bisphosphonate, or radiotherapy. Pain management: mild pain, you have to give paracetamol or NSAID, and mild to moderate pain, weak opioid like codeine or paracetamol or NSAID. Severe pain morphine can be given with paracetamol. And now for there's this conversion. These questions are also very much common, keeps on coming. Conversion between opioid. So oral codeine to oral morphine, divided by 6, divided by 10. Oral tramadol to oral morphine, divided by 5, and oral morphine and oral oxycodone, divided by 2. So there are the codes here: CM10, TM5, and MO2. The BNF states that oral morphine sulfate 80 to 90 mg over 24 hours is approximately equivalent to 25 microgram per hour patch. Therefore, product literature should be consulted. And from oral morphine to subcutaneous diamorphine, divided by 3, that is MD3, and oral oxycodone to subcutaneous diamorphine, divided by 1.5, so OD 1.5. So these are the codes that needs to be remembered: CM10, TM5, MO2, MD3, OD 1.5. Management of hiccups and palliative here. Peppermint water and antacids are the first line. Domperidone or metoclopramide can also be given. Dexamethasone orally can also be given. Levomepromazine, haloperidol, and baclofen may be recommended by specialists. In the terminal phase of the illness, then care of dying pathway, then agitation or restlessness must be treated by minerazole. So in the terminal phase of the illness, it can be treated by minerazole, can be given as well. Okay, moving to the more important topic, toxicology, very important as well. So what actually you do for different medicines toxicology section? Mechanism. Also you have to understand the mechanism, what's happening. Alcohol withdrawal. So chronic alcohol consumption enhances GABA mediated inhibition in the CNS, something similar to benzodiazepine, and it inhibits NMDA type glutamate receptors. So it enhances the GABA mediated inhibition in the CNS. So alcohol withdrawal is thought to lead to the opposite. It decreases the inhibition of GABA and increases NMDA glutamate transmission. So alcohol withdrawal presentation would be, what you have to remember is decreasing inhibitory GABA and increasing of NMDA glutamate transmission caused by alcohol withdrawal. So the presentation would be symptoms: tremor, anxiety, agitation, and sweating. That's for 6 to 12 hours of withdrawal. Peak incidence of seizure at 36 hours, not at the onset. Peak incidence of delirium tremens is at 72 hours. So this is the one you have to check out for. The management would be use clinical institute withdrawal assessment for alcohol revised protocol to assess and guide the treatment. Benzodiazepine can be given. Carbamazepine is also effective in the treatment of alcohol withdrawal. Phenytoin is said not to be as effective in the treatment of alcohol withdrawal seizure. So recommended alcohol limit is 14 units per week for women and men. For salicylate overdose, a key concept for the exam is to understand that salicylate overdose leads to a mixed respiratory alkalosis and metabolic acidosis. So RAL and metabolic gas, RAL-MAC. Early stimulation of the respiratory center leads to a respiratory alkalosis, while later the direct effect of salicylate combined with acute renal failure may lead to an acidosis. Okay, in children, metabolic acidosis tends to be predominant. Mixed respiratory alkalosis and metabolic acidosis in a sweaty, confused patient point to a salicylate overdose. So this is something which can be in the question papers. The development of pulmonary edema suggests severe poisoning and is an indication of hemodialysis. So if you remember, salicylate is dialysable from the previous note. Okay, so the features for salicylate overdose will be hyperventilation, centrally stimulates respiration. That's what's causing the respiratory alkalosis. Tinnitus, lethargy, sweating, pyrexia, nausea, vomiting, hyperglycemia, hypoglycemia, seizures, and coma. Management will be general ABC, charcoal within 1 hour of ingestion. Urinary alkalinization is now rarely used. It is contraindicated in cerebral and pulmonary edema, with most units not proceeding straight to hemodialysis. So since cell circuit is dialysable, they can go for dialysis if the condition is pretty severe. Cell circuit causes the uncoupling of oxidative phosphorylation, leading to decreased ATP, increased oxygen consumption, and increased carbon dioxide and heat production. So what are the indications for hemodialysis in this case? Serum concentration more than 700 milligram per liter, metabolic acidosis raised into treatment, acute renal failure, primary edema, seizures or coma. Okay, paracetamol overdose. Management is start an acetylcysteine immediately. Naloxone if there is hypoxia or respiratory depression. Okay, so King's College. So firstly, the management is start an NAC and N-acetylcysteine immediately. Naloxone if there is hypoxia or respiratory depression. King's College Hospital criteria for liver transplantation for paracetamol liver failure is arterial pH less than 7.3, 24-hour ejection, or all of the following. PT more than 100, creatinine more than 300, grade of 3 or 4 encephalopathy. Very important. This came in the exam as well. IV acetylcysteine is indicated for the treatment of paracetamol acetaminophen overdose. When paracetamol is taken in large quantities, a minor metabolite called N-acetyl benzoquinone builds up. It is normally conjugated with glutathione, but when taken in excess, the body's glutathione reserves are not sufficient to inactivate the toxic NPQI. This metabolite is then free to react with the key enzyme P450, therefore damaging hepatocyte. For this indication, acetylcysteine augment the glutathione reserves in the body, and together with glutathione directly binds to toxic metabolites. And these actions serve to protect hepatocyte in the liver from NPQI. So this is the mechanism of how N-acetylcysteine is saving the liver. The following patients are at increased risk of developing hepatotoxicity following a paracetamol overdose: chronic alcohol excess, patients already on P450 inducers, anorexia nervosa, HIV. Next is cyanide. It may be used in insecticide photograph development and production of certain metals. Toxicity results from reversible inhibition of cellular oxidizing enzymes. Presentations can be classical features: brick red skin, smell of bitter elements, acute hypoxia, hypotension, headache, confusion, chronic ataxia, peripheral neuropathy, dermatitis. Management will be supportive, 100% oxygen, and definitive IV dicobalt editate.